Good afternoon, everyone. So it's another day of our usual grand round session. Today, we are very delighted to have Professor Moritz Wildgruber from Germany in person. He just arrived like 2 hours ago, and he's going to give us a talk on vascular anomalies. So you're warmly welcome.
Recording in progress.
Here, now we are. Perfect. Wonderful. So thanks so much. Great to be back again. Eric told us we have to be quick, so we rush, give a short introduction to the topic. And one important thing is that we give a quick glimpse on the classification of vascular anomalies. And this is important because there are distinct entities, and frequently, and this is a worldwide issue, they are referred to as hemangioma. And every vascular lesion is called a hemangioma, but of course, not every vascular lesion is a real hemangioma. Actually, most of them are not hemangiomas. And we try to find out what is actually what. And the most reasonable classification, although it's not perfect, is the classification that was developed by the International Society for the Study of Vascular Anomalies. And they make a principal distinction into vascular tumors and malformations, meaning you have on the one hand diseases that share characteristic of a proliferating disease with increased cellular turnover. And on the other hand, you have real dysplastic diseases where the tissue is not characterized by increased proliferation rates. And of course, and we'll see that later on, the world is not always black and white. There are things in between. And there are indeed vascular malformations that can proliferate and can have increased cellular turnover. But nevertheless, it's useful to use this classification because it makes a complex word a little easier. Okay, so with the vascular tumors, we have further three distinct entities: benign tumors, locally aggressive vascular tumors, and malignant tumors. And then we have the vascular malformations, the dysplastic diseases. And those are further divided up on the kind of vasculature they affect. So when they affect only the capillaries, they are called capillary malformations. If they primarily affect the lymphatics, they are lymphatic malformations, venous, arteriovenous, and then there are, of course, a lot of mixtures: veno-lymphatic, capillary, arterial, and so on. Every combination essentially exists. And this is important, and this also shows why the vascular malformations may not always be vascular malformations. It has been described that many vascular malformations contain genetic mutations that otherwise are found in malignant tumors like colon cancer. And this shows that indeed vascular malformations may be able to proliferate. So we give a quick glimpse on the vascular tumors. Most of them are very easy, and there are a few very rare ones. And this is actually the only lesion which is a real hemangioma. Yeah, you see these raspberry-like, tumor-like lesions that can occur in every part of the body. They can be quite large. The good thing is, for most of the time, they vanish by their own. So infantile hemangiomas, and another important characteristic you see here on the slide, is a typical disease only of small children. Yeah. If you have an adult patient, it's very, very unlikely that this patient has a real hemangioma. And this is important to know if you see a patient, a child with a real infantile hemangioma, these lesions have a very characteristic growth kinetic. So typically they are not present at birth. They occur within the first months of age. Then they have a strong proliferation rate. They grow, they grow, they grow, usually until the kid is 6 to 12 months old. And then they go into a regression phase. And this regression phase may differ, but it may take several years. But the good thing is, you see here on the black line, most of the infantile hemangiomas, they vanish by themselves. So no need to treat. And if you want to treat them, if they are, for example, in areas that are problematic, so if they occur around the orbit and the child may develop impaired vision and you need to treat it, then there is it was an incidental discovery. Propranolol, a beta blocker, which is usually given to lower blood pressure, is a very potent drug to speed up the regression phase of the hemangiomas. So for interventional radiology, very rarely one has to treat real hemangiomas. I only remember one case in my life where I had to embolize a real hemangioma. So watch and wait is the best you can do. And if the hemangioma is in an area that is really causing you trouble, you put the child on propranolol. Locally aggressive vascular tumors are very rare, and you don't have to keep that in mind particularly. That was a very rare case that initially also was called an hemangioma because it also looked a little bit raspberry-like, but it didn't stop to grow. Propranolol had no effect on this. This is always a sign that there's something else going on because propranolol really works in almost every hemangioma. And this disease was accompanied by a severe thrombocytopenia. And this is a very rare tumor called Kaposiform hemangioendothelioma, where the tumor by itself destroys the thrombocytes, and the children are at risk of bleeding because the thrombocytes are too low. These are the MR images of the kids. So you really see a kind of tumor-like blush. This is also important when differentiating malformations from vascular tumors. If you really have a homogeneous blush on the MRI or on the CT or something like that, then it's really more likely that you have a tumor. If you have these kind of spaghetti-like vessels all around, then it's more likely that you're talking about a vascular malformation. We can skip this for the sake of speed. This is also not very exciting. And the malignant vascular tumors that essentially belong to the ISFA classification are angiosarcomas, which are rare but highly aggressive malignant tumors. They frequently cause lung metastasis, and also as they derive from vascular structures, they can occur in every part of the body where there are vessels around. So every tumor essentially can be an angiosarcoma. But luckily, they are very rare because they are highly malignant. Okay, capillary malformations. Originally called the so-called port wine strains, they exist all over the world, are characterized by dysplastic capillaries, and for most of the time, you don't need to do anything because they do not hurt, they do not cause any damage to the child, they are only a kind of aesthetic issue. But when you see a segmental capillary malformation, remember, what do you have to think of? Syndromic diseases like Sturge-Weber disease or something like that. Yeah. So if you have a really symmetrical capillary malformation, especially in the face, think if this could be, if there are other features around that could point, for example, towards a Sturge-Weber syndrome. And then you'd have to treat the Sturge-Weber, not the capillary malformation, of course. Lymphatic malformations, lymphangiomas, cystic hygromas, they also have multiple names. It doesn't matter. We're all speaking of the same disease. There are two different kinds of type classified by the anatomy: macrocystic, where the cysts are larger than 2 centimeters, microcystic, or mixed type. And of course, lymphatic malformations, as I said before, can also occur in together with venous malformations, with capillary malformations. So everything can be mixed. Typically or very frequently, lymphatic malformations, cystic hygromas, are located around the head and neck area. So about 70% we find actually in the head and neck area. They do not regress by themselves. Sometimes one has the impression that they do. And what happens in those cases is a kind of autosclerotherapy. That means if the children get infections, standard classical respiratory infections, also the cysts get infected. There's a lot of inflammation, and then sometimes the cystic walls kind of scar and grow together. And then if the child goes through multiple infections in the winter or whatever, then the lymphatic malformations can kind of regress by themselves because the inflammation essentially kills the cystic hygroma itself. Looking at the biomedical imaging studies, it's important that one can distinguish venous from lymphatic malformations, and that's very easy because when you give contrast agents, the lymphatic malformations don't fill up with contrast, because they're not attached to the circulation. Only the very kind of rim enhances a little bit, but the central parts stay dark. If those would get bright, then it would be a venous malformation. So very easy to distinguish. Of course, it's getting problematic when you have mixed type. So what to do? If the surgeons can resect a macrocystic or a cystic hygroma entirely, then they are welcome to do it. Most of the time, it's actually hard. So we can offer sclerotherapy, which already explained the therapeutic principle. Thanks. Is very easy. You cause inflammation within the cystic hygroma, and then the cyst walls kind of scar together. Then the compartments do not fill up, and the symptoms go along. You can use various agents for sclerotherapy. They all have distinct characteristics, and I think you guys here have used all of them. Bleomycin is very common worldwide. You have to take a few precautionary measurements because officially it's a chemotherapeutic agent. Doxycycline, which is originally designed as an antibiotic, is also a very good sclerosing agent in the cystic hygromas. Doxycycline does not work very well for venous malformations, for example, but for lymphatic malformations, it's also a very good drug. The way we do it is we puncture the cyst, we put in some kind of sheath or catheter, get rid of the fluid so that you don't have a high dilution effect of your sclerosant. Then you inject whatever you have, doxycycline, bleomycin, whatever is available, and you let the inflammation go on. And if you feel it's necessary, you can leave the catheters in, and you can do a bedside sclerotherapy on the next day if you feel another shot of therapy is needed because the lesion is very large or problematic in some way. Venous malformations, they are the most frequent vascular malformations. And what happens there is a little bit similar to varices, but congenital. So differing from hemangiomas, you learned hemangiomas are not there at birth, they occur later on, then they grow. Venous malformations and all vascular malformations are already present at birth. And what happens essentially is that the vascular wall lacks smooth muscle cells. And if the smooth muscle cells in the vascular wall are gone, then the vessels tend to dilate and form cavernous structures that give rise to local thrombosis. This causes pain and discomfort in the patient, and then you have to treat it. Typically, the lesions are bluish, when you see it here around the lip, on the T2 exams, you have these very bright cavernous compartments, and when you give contrast, they slowly fill up with contrast. Treatment of choice, sclerotherapy, puncture, make sure you're in the blood vessel. You can inject a little bit of contrast agent to see if you're right and how the contrast distributes along the area. And then again, you inject various kinds of sclerosant agents. Polidocanol is a very safe drug. Also, bleomycin is quite safe. Ethanol is very, very effective, but it's also highly dangerous. So injecting pure ethanol, I would be very careful with that because it really can cause relevant nerve injury. Again, here, an example of a kind of rather extensive venous malformations. You even see these small dots, phlebolytes in there, and sclerotherapy is the good therapy of choice. Arteriovenous malformations are the most difficult ones to treat because they have a high flow character. So the arteries are pumping blood in there, and arteriovenous malformations are essentially characterized because they lack the capillary bed. That means usually the blood comes through the artery, goes through the capillary, and then to the vein. In AVMs, the capillary bed is missing, meaning the artery is shunting directly to the vein. And that leads to a kind of high flow and high pressure within the veins. And that also is the explanation why AVMs are continuously increasing in size, because they continue to put pressure on the venous system. The venous walls cannot resist the high pressure, and everything gets bigger over time. And the kind of strange thing about AVMs is that, for example, if you have it in the extremity, you have a high blood flow through the extremity, but the tissue is getting ischemic because the capillary bed is missing and there is no O2 extraction in the capillary bed. And due to the shunting, additionally, all the blood, all the oxygenized blood is essentially flowing through the extremity, but not getting to the tissue. Clinical wise, it's very easy to distinguish arteriovenous malformations from venous malformations. AVMs, because they have the high flow, they are pulsating. On the skin, they are red, and the lesions are typically warm or overheated compared to normal tissue. Venous malformations, as we saw, they are rather bluish. There's no increased temperature, and of course, they are not pulsating. And if you keep these three items in mind, you can make the diagnosis without any imaging. So here, typically AVM, red spots. You can have ischemic ulcers because, especially in the periphery, as I said, because the tissue is getting ischemic. On the other hand, venous malformations, rather bluish, not pulsating, and not overheated. There are angiographic classifications that are important for us because they may tell us how we can treat the lesion. So, for example, a type 1 AVM, which is very typical, for example, in HHT, Osler's disease. This is a very good lesion to be coiled. Yeah, you come from the artery, you put the coil somewhere here, and the disease is solved. Type 2 is much more difficult. If you have, however, this very large dominant outflow vein, you can come from the venous side and embolize with liquid embolics, we'll see examples later, from the venous side. Type 3, with this fine fistulous nidus, you can either come from the venous side or from the arterial side and do it with liquid embolics. And also when looking at these sketches, you see if you place coils in that lesion, that has no effect at all. Yeah, you can only reach a few vessels and the AVM will stay perfused. The MR imaging beforehand helps you to distinguish that and classify the lesion properly. And frequently, if the AVM exists already over years, you can see these dilated veins, which already look like almost like venous aneurysms. And two things to take care of on the imaging. If you have black spots on the imaging, make sure that you distinguish, is it a flow void because of high blood flow, then it's an AVM. Or if you have phlebites in the lesion, has nothing to do with flow, these is typically for a venous malformation. When treating AVMs, there are a few principles. We talked about that. It does not make sense to treat only the artery because the disease in AVM affects the artery and the vein. We have to treat both. If we only treat the artery, new arteries will come and feed the diseased vein. When you treat an AVM, you have to treat it completely. You have to cross the finish line and you cannot stop in between, because if you only treat it a little bit, the rest will recur. And typically, one would clearly refrain to do surgery as the first therapy of choice, because open surgery of AVMs are really a mess. The surgeon will never be able to take out the AVM entirely because it's bleeding like hell. Then they have to close. Rest of the AVM will stay in place and will continue to proliferate. Yeah. What is a very good therapeutic option, though, and therefore we have to stay friends with the surgeons, embolize, make the lesion dry, and then tell the surgeon to take it out. Yeah. And then he also has a much nicer life, because resecting an embolized AVM is much more fun than just cutting blood vessels. In some, especially in the distant extremities, you cannot cure these lesions. If you would embolize all this completely, the guy would lose the hand. And also in this case, it was not possible to rescue the entire extremity. Here you see the result of this AVM. There was a lot of blood flow, but the blood just shunted directly to the vein, went back to the body, and the finger did not get enough blood and became ischemic. So we embolized the AVM, and then the plastic surgeons had to resect part of the hand and the fingers because just the tissue was already dead. This is a sad case of a young guy. I always show this to warn the surgeons. If you do direct surgery on the AVM, you can even set a proliferative shot to the AVM. That means if you cut some vessels, the AVM, like a tumor, realizes I'm not getting enough oxygen and it starts to proliferate. And therefore, one should not do partial resection of AVM, and also one should not embolize a little and then send the patient away. You have to embolize completely. In this case, you see the lesion went to massive proliferation, and this was not handleable anymore, and the patient had to be amputated, which would have not been necessary if it would have been treated properly. But also we as interventional radiologists can make it wrong. I told you, don't coil AVMs. It's not a good therapy. Here you see some loosely placed coils in the feeders of the AVM. And what was the effect? Nothing. Yeah. There's enough neoangiogenesis that the lesion stays alive. And if you do it with liquid embolics, you can kind of devascularize the lesion almost entirely. And when you have done that, then you go to the surgeon and say, hey, please take this out. Yeah. And then they're resected. They will always tell you, I got everything out. I did an R0 resection. Then you go and take an X-ray and show him the liquid embolics that he has left in place. And you can teach him how to do it properly. This is the way how the liquid embolic works. Showing this on the table does not make sense. You really have to experience that by doing it yourself. And I know we have plenty of chances to practice that here. That all these techniques share the same principle. You have to treat the artery and the vein, yeah, and not only the artery. This is very, very important, yeah. So treat the nidus of the AVM, the center, not only the feeders. The difficult locations where the transarterial way may not be the proper one. Here you see an AVM of the forehead, which came out of the ophthalmic artery. And of course, if you embolize the ophthalmic artery, it may not be a good idea. Here you see the arterial blush of the retina, and you should, of course, not leave any liquid embolics around here. So we tried to embolize it the arterial way, past the branches to the retina. It worked a little bit, but we were not able to close the nidus entirely. So you see there's only a little bit of liquid embolics in the AVM. So we did an additional percutaneous puncture, which can also be done very easily in those cases. And then you inject your liquid embolic via the direct puncture. And at the end of the day, the AVM was embolized completely. The surgeons could take it out, and the ophthalmic artery was still present. That was the result. Then after the surgical resection, hardly any more to see. We can skip this for the sake of time. This is another terrible case. So yeah, to summarize the AVM story, make sure you distinguish AVMs from venous malformations. I told you this is preliminary a clinical diagnosis. Pulsating, yes or not, warm, yes or not, red or blue, and then you have the diagnosis, venous or arterial venous malformation. You do your imaging for therapy planning. You think of the classification. Do you have a dilated vein that could be a good access? Is there possibility for direct puncture? Or is it a very anatomically easy lesion with not a lot of feeders, and that is the only situation where one could place a coil or a plug or something like that? AVMs are progressive throughout life, and they cause two problems. The first one we've already seen, local ulcer and necrosis. And if the arteriovenous shunting is getting too high, then there may occur an overload of the right ventricle, and the patients may go into right heart failure. That means AVMs really need treatment. Venous malformations, if they don't cause harm, they can also be left alone because they are not progressing. Again, treat the nidus, not the arterial feeders. This holds for us as interventional radiologists. It also holds true for the surgeon. Try to be as complete as possible in AVMs. If the lesion is embolized properly and you have a good surgeon, ask him to take it out. It decreases the rate of recurrence. Don't stop in between, cross the finish line as best as you can. Otherwise, there will be a high rate of recurrence. We learned that genetics are getting more and more important in these diseases, but we're just about to learn about this. So this is a small boy with an, see it here on the lower right-hand image with the AVM in the leg. And that was a kind of strange syndrome. You saw the right foot is bigger than the other one. There's also a little bit capillary malformation. And we did a biopsy and found a so-called KRAS mutation, which surprised everybody because KRAS mutations, for example, are typical in colon cancer. And one would not expect this in a dysplastic disease in a young child. But this may tell us in the future that these lesions may be able to proliferate like cancer, and that one needs to treat them already early in life. Okay, so quick wrap up. Very heterogeneous diseases. I told you, try to use the ISFA classification. It's not perfect. This distinguishing between vascular tumors and vascular malformations. I mean, why do we classify? We classify because we want to make a complex word a little easier. But of course, the world is never black and white. There's always something in between. And so also this classification is not perfect, but I think it helps to get into the field and understand the diseases a little bit. And very important, vascular anomalies are never the disease of one certain profession. You need a lot of professions that may be involved and that need to work together. And yeah, here this is already practiced. Very nice. And with that, I think I'm finished. And if there are any questions, happy to discuss that.
Thank you so much. I was confused recently when you have the talk. There's a lot of things normal. There's a vascular malformations and the venous anomalies. So vascular anomalies, like there's
a lot of mixture. Yes.
Usually also mix a lot.
Yeah. As long as you treat the patient right, it's okay. Yeah.
The diagnosis matters and the treatment wise. When some people that are treating vascular malformation as if 8 years. So
this is stupid. And then you have to react. Yeah. And if for example, if we frequently see patients with vascular malformations and they are fed with high doses of propranolol. Yeah. And of course, this is stupid. Yeah. And then you have to realize, hey, it may not be a hemangioma. It's not an error if you call it a hemangioma, but if you feed an adult with propranolol, then it's stupid. Yeah.
Thank you so much. Because of time.
Professor, please elaborate some more on the arteriovenous malformation, the types. You mentioned about type 2 and type 3. The approach is different in the management. One, you come from arterial, one from venous. Please explain some more.
Yeah. But there is no strict rule. So it's not kind of needed that you come, for example, only from the venous side or only from the arterial side. But this classification may help you in getting kind of most effective. Yeah. So as I said, it's really important that at the end of the day, this part here, where the artery is abnormal and where the vein is abnormal, that this part is excluded. And if you leave something open, then there is a high risk of recurrence. And for example, if you have a type 3 lesions, it will be very hard to reach it via the transvenous way because the veins will get very small and your catheter will not go all the way to the lesion. Yeah. However, if you have a type 2 lesion where you have one large fat draining vein that easy takes your catheter until the end, then this may tell you, hey, I might try it first the transvenous approach and see how successful is it to come through that path. And honestly, so this classification is a help, but frequently we actually combine the approaches. Yeah. Frequently we go for example, as I showed you, transarterial way and additional direct puncture. Works well in some lesions. Yeah. If the nidus here, if the vessels are very, very tiny and very small, like in this type 3A lesion, however, a direct puncture may be very hard to achieve because you only hit a very, very small vessel. Yeah. And you cannot embolize a lot. Yeah. And of course, this classification shows kind of prototypes of lesions. In the real world, they always look a little different. But this is the purpose of the imaging, to give you an idea, how can I reach the lesion? How can I make sure that the artery and the vein is killed at the end of the day. Yeah. And you don't need the imaging for diagnosis, but you need the imaging to guide you. How can you reach this area properly? Yeah.